Welcome to Talkin' Maine with a Bow Tie Boy. I'm Tom Savviello. And Abhi, you're my guest. It's good to have you here. Now, you pronounce your name.
My full name is Abhishekh.
Abhishekh?
Yes, but I go by Abhi. It's a little bit easier.
Yeah, it's a little easier. So we're going to talk about the emergency room, but first let's talk a little bit about Abhi. You know, how did you become a doctor? I mean, you were telling me you were with Fox News. Were you Tucker Carlson's partner?
I met him once when Fox News first started. Tucker Carlson, I think Eric Snow. I came out of undergrad. I wasn't really sure what I wanted to do. It's hard, you know. It's hard when you almost have to decide what you want to do when you're 13, 14 years old. You get into a good high school and so forth. So I was one of those kids that I really didn't know what I wanted to do. So I came out and I did broadcast journalism. Fox News was starting out at the time, so I worked for a local affiliate in Nebraska. And then I switched over to ABC, the ABC affiliate, because that's where I had done my internship. And they knew me, and so I did that for a little while, and that wasn't quite working. So then I went into sales and advertising, and I was an account executive, and that didn't quite work. So my father was a physician, and he always told me not to do it. So I did what he told me not to do, and I went into medicine.
Wow. No, I forgot. You're from Fiji.
I'm from Fiji.
Do you still have family in Fiji?
I do. I have family in Fiji, in Australia, in New Zealand.
Really?
I do.
So, wow, that's cool. I mean, I've been to Australia, and I have a friend who retired out of the mill, went to Fiji years ago. So someday maybe I'll go.
I hope you get to go. It's a beautiful place.
So now you become a doctor. So give us the litany of how you got there, and then how you ultimately got up here in Farmington.
Well, it's always about a woman is how I get to Farmington.
It's always that way.
But I decided to go to medical school, and to go to medical school after you've done something else is difficult. And like I said, you almost have to decide in high school that I want to go to medical school and get everything together. So I applied to a whole bunch of medical schools in the United States. I was put on wait lists, and I didn't really want to wait. So I went to medical school in the Caribbean. I did 2 years there. Then I did my third year of medical school in London. Wow. And then my fourth year of medical school in New York. And I got out and got into a surgical residency because I thought I wanted to be a surgeon. During my residency, they told me I was too kind. I wasn't mean enough to be a surgeon. So after 2 years of doing that, I went and actually did my residency, or my board is in family medicine. So I have a very broad background, and I wanted to practice more inpatient medicine than office medicine, and so I became a hospitalist. We had 2 little girls when I was coming out of residency, and we needed more help. It's hard to raise kids in New York City and so forth. So we moved to Maine because my wife is from Maine, like I said. It's always about a woman, in my case 3, because I have 2 little girls. And so we moved to Maine. And I came to Franklin because I love the community. I love the hospital. You know, they're wonderful, wonderful people. And I was a hospitalist for 3 years, and then they had an opening in the emergency room, and I switched over, and that was about 7 years ago.
So you were one of the emergency room docs then for a while, correct? When you say you switched over to the emergency, and when did you take over as the kind of the leader of the emergency group?
2 months ago.
2 months ago. Oh,
2 months
you're really
ago.
a rookie at this right now.
Well, I'm a rookie at being the director of the emergency room, but honestly, I've been there longer than any of the other docs there.
Wow. Well, of course, the emergency room, sadly, is the place you really have to go when you got a problem.
You don't want to see me. I'm the doc nobody wants to see.
So are you actually doing shift work yourself, or are you just doing?
I am.
So you're actually a working leader.
I'm a working leader.
I have my favorite kind. I hate those guys that sit in the ivory tower, but you would have already earned that right to do there. So tell me a little bit about the emergency room. A lot of people, they understand. I mean, one of the big questions I asked, and I've told Ryan I'm going to ask it, how come I always got to wait so long? If it's an emergency, I show up at the emergency room and I'm still waiting there. But we'll come back to that question. So what are some of the kind of emergencies people should really think about versus going to the primary care physician?
Things that constitute an emergency. I think a lot of times we feel like if something's happening to us, it's an emergency, but that doesn't necessarily mean it's an emergency from a medical standpoint. Anything that's life-threatening is an emergency. A stroke, a heart attack, obviously, things like broken bones. Obviously, if you break your bone, you have a bone sticking out, you're not going to call your primary and wait, to see them tomorrow. You're going to come to the emergency room. Big cuts, things that need sutures, those are emergencies.
Yeah, and that's kind of what I've always gone by. But you still have, because so you really, one of the emphasis is to people that might be watching this, if you don't have a primary care physician, get one, because ultimately they will be the ones that will direct you to the emergency if you're have something happen to you on the weekend, and you can call them rather than show up at the emergency door.
Absolutely, absolutely. The hard thing about Western Maine and the area which we live, and Franklin covers a very, very large section. I mean, upwards of Rangeley, Sugarloaf, Stratton, Eustis, all the way down to Livermore Falls. So we are the access, and that's what I think people here are finding it difficult, is that there aren't a lot of primary care physicians. We really need a lot more primary care physicians. So we are access. We are there when you can't get in to see a primary, or you don't have a primary.
Yeah, and that becomes the place in the hospital. So I can go to the hospital; they'll take care of me.
They'll take care of me.
So I may come in with a really bad cold or a head ear infection or something, and I have no other choice to go to, and go to the emergency room. So when you get to the emergency room, walk us through. I come to the emergency room. What happens? What do I do?
You come to the emergency room. You're seen by a nurse who triages you. They get your symptoms, how long it's been going on for, and then it depends on whether or not we have beds. Our emergency room is a 10-bed emergency room. It fills up pretty quickly. You can imagine, 10 people, it's not a lot. So if somebody comes in and they have a runny nose and earache or a toothache, as opposed to somebody who's coming in with chest pain or who can't speak, we have to prioritize. We have to triage, like, what do I need to go back? And even if I don't have a room, who needs to come back next? So depending on your complaint, you may have to wait, and I don't say it in a mean way or anything else. It's just the priority level for someone who's having a heart attack is not the same as for someone who has a toothache. And you may complain like, look, I got this cut, or hey, my ear hurts. I've been dealing with this for 2 days. You don't understand. Well, it's not that I don't understand. It's just that, unfortunately, in terms of priority, it goes down the list. And
I don't know what's going on in those other 10 rooms.
Absolutely.
All I see is maybe 3 rooms that are empty, and I'm sitting out there waiting, and I'm saying, what's going on? There's empty rooms, but you could be working on somebody that's had a heart attack or a stroke or has bad cut that needs to be sutured up or broken bone.
Absolutely, and a lot of times I am the only doctor on, especially at night. I'm the only doctor on. So if I have, let's say, someone who comes in that's a bad trauma, which we see a lot of around here. If I have a bad trauma, I need to be in that room. If I have somebody who's having a heart attack and I'm doing CPR, I cannot kind of be in that room. I have to be in that room. And that'll take out 45 minutes to an hour of my time. And if I'm the only doc and I'm in one room for 1 hour and I still have 10 other patients in rooms waiting to be seen, it may look like, well, you guys don't look like you're doing much. It's just that when you're the only doc, I can't be in multiple places.
So in the emergency room, how do you staff it up? So how do you know how many nurses, how many docs, how many PAs? How do you staff that up? And are you changing that staffing as we go forward into the next couple of years? At night the staffing at night is different during the staffing at night is different than it is during the day. During the day, I feel like we have more people. At night, it's more of a skeleton crew. You try and go by historically the number of patients that we're seeing. So if in an overnight period, let's say we see 5 patients, then I don't need to have 3 nurses on at night. I can get by with just having 1 nurse or 2, a nurse and a tech or something like that. Now, we've gone by historical data. The problem is that we are now getting busier and busier and busier, and we're using the same staffing models. Now, we know that we need to get more nurses, we need to get more techs. The other problem is we can't. We cannot get enough people, we cannot get enough nurses.
we had a surge the other night, and what I mean by a surge is all of a sudden we had, and it's not uncommon for 4 ambulances to come in at the door at
Really?
once.
Wow.
4 ambulances to come in, 10 people to come in within the hour. If 10 people hit my door within the hour, you can imagine it's going to be gridlock. And if I've staffed with 1 nurse and 1 tech, and all of a sudden now I have 10 people who have come in at once, we try and call people in, we try and bring in, but it just doesn't happen. So we need more nurses, we need more techs, but people aren't going into it, and it's hard to staff, and it's now things are getting more expensive, the cost of living has gone up. So it used to be a good paying job. Now it's, if I can work at Subway for $15 an hour, and why would I work in the emergency room if I'm getting $17 an hour, So,
but less stress, less pressure on it.
Absolutely.
Yeah. And I don't have to have the education that I do to become a nurse.
Absolutely.
Yeah. My mom was a nurse. She did not work emergency room. She worked maternity, and then she was just a general nurse for a long time. Actually worked until she was in her 70s.
Wow.
Because when she moved down to Tennessee where they retired, they had a small hospital similar to Franklin, and they had a nurse shortage. So they advertised for anybody who had their degree. It was funny because she came back, she said, well, when I was a nurse, I didn't have to put IVs in. Now I do. So it's like, okay. So and she did it. She did it for a couple of years, and then she said, okay, I've done it for a while. Now, are the docs there? Or are they on call for the emergency room?
No. The docs there is a physician there 24/7. At least 1 physician. And we've recently switched to a model where we had a physician and a physician's assistant during the day. We've recently switched to having 2 docs during the day.
Wow.
So now we have 2 doctors during the day and then 1 who's there at night.
And you have the same struggle up here with docs. It's recruiting them.
Absolutely.
They come up here because we're in a rural area, and if they want the city, it's tough for them to say, well, I'm going to live in Wilton, Maine or Farmington, Maine, because no, there's nothing here. Well, there is stuff here, but you have to make it happen.
There is stuff here, but it's also much harder because we don't have specialists up here. So if you need a cardiologist, if you need a neurologist, if you need any kind of a specialist, I've got to get you to Portland or Lewiston or Bangor. So as a doc, it's much more challenging. It's much harder to work in a small emergency room because you have to do so much more. And a lot of the docs in a big, like Maine Med ED, luckily, we have 4 new docs who we've just got, who are starting. 2 have just started this week, and 2 will be starting next week. So we've got 4 brand new physicians who I'm very, very excited about. But the thing that they said is, well, this person's having a heart attack. We need a cardiologist. I said, well, you're going to have to be the cardiologist right now until you can stabilize them and get them to Lewiston or Portland. Yeah.
Wow. I mean, that's why I said the emergency room in a small hospital, if I were a doc, that's where I'd want to be. I want to be able to have all these different challenges coming at me because I get bored and I have ADD. And so I need
Can we get you to med school?
No, I don't think it's too late. It's too late. Too late. No, I would not be happy. And I probably would get fired because I'd be like you. I'd be too nice of a surgeon or too nice of a doc and so forth. So but let's just walk through a stroke and a heart attack, because those are 2 of the big ones. What are the symptoms of a heart attack, and then how do you guys handle that when that comes into you?
So they're different heart attacks. It's not as I'm going to make it really straightforward. Symptoms of a heart attack. Usually symptoms: left-sided chest pressure. It can radiate into your neck. It can radiate into your arm. You can get very sweaty. Sometimes you're not. But even that presentation is variable. I have seen patients who've come in just with arm pain who are having a heart attack. I've seen patients who've come in with abdominal pain who are having a heart attack. So it's not always like a textbook. My patients don't walk out of textbooks. They come in with very different presentations. But usually, if you have pain, pressure on the left side of your chest that's going up into your neck and your arm, that's what you worry about. Whether or not you're having a heart attack. And obviously it goes along with, do you have a history of having a heart attack? Do you have a history of having high blood pressure or high cholesterol or diabetes? So these all contribute to whether or not you're having a heart attack. 18 or 19 years old and you have chest pain that's going into your arm and you're otherwise healthy, the likelihood is you're not having a heart attack. You know, you may worry that you're having a heart attack, but the likelihood is you're not. But so age, comorbidities, things like that, along with these symptoms, you know, you're having a heart attack. When someone presents, whether they come in by ambulance or whether they come to, and a lot of the bigger heart attacks I've seen, patients have just walked up.
Really?
And registered. Yeah, absolutely. Absolutely. And those are the hard ones because at least on the ambulance, they've hooked you up to a monitor, they've got an EKG. But if you walk up to the door, you know, what if I've got 10 patients already there?
Yeah.
You know? So, and we have seen that. And again, someone who walks up to the door and says, look, I'm having chest pain, we try and see those patients right away, regardless of how many other people are waiting. We try and at least see them and get an EKG. You can have, if there are changes on the EKG, then we start to get lab work. If there's a certain criteria on the EKG where it looks like you're having a heart attack on the EKG, in that case, it means that the blood vessel to your heart is blocked and we've got to open that back up. Now, I can give you certain medications to do that. It sometimes works, it sometimes doesn't. But ultimately, what I need to do is get you to a cath lab as quickly as possible. Whether it's Lewiston, whether it's Portland, whether it's Bangor, wherever it is, I have to get you there as quickly as possible. And that's what we do.
So basically, to tell it I have a heart attack, you are going to hook me up to an EKG.
Absolutely.
I've always wondered, because you're not going to listen to my heart and it's not going to change it there. But if you hook me up and you can see whatever blip is not blipping, right?
Correct.
Wow.
Yes, whatever blip is not blipping, right? I like that.
Yeah, whatever blip is not blipping. Well, I did an EKG years ago and they came out and said, oh, you have a right bundle block. Oh, yeah?
Yep.
What did I do? I don't know, but you got one. So I have a right bundle block. I don't know what that means, but anyway, I'm still alive.
And some of that is, you know, I try and compare if you have an abnormality. Not all abnormalities are a heart attack. And if it's something that you've had, then that's just the way your heart is.
Yeah, well, I actually went through the whole process because I told Dr. Ben, who's my doc, that I had some pains in my chest. And so immediately he said, okay, now you got to go get through the whole gamut. So I went through the whole gamut. The good news is I have no problem. The good news, I do have a heart, contrary to what some people believe. I actually saw it. So, and they were great when they put me through the whole exercise. And I would encourage anybody who doesn't feel right, make sure they tell their primary care physician.
Absolutely.
Because I went through all the tests and I came back and the answer was you're going to live till you be about 90, so don't worry. And I know it's true that the good die young, so I'm going to be around a long time. So let's do the same thing with the stroke, because that's the other big one. I mean, I had an interesting experience. One day I came home and I literally could not connect between I knew your name was Abby, but I couldn't say it. So I looked at you and I kept saying, I know who you are, but I can't say it. I had an experience same day as I knew that the gentleman I was talking to was my friend's son, but I couldn't name him. So I went home and Christine was there and I said, where did we eat dinner last night? So she holds up the menu because we brought it home and I knew right where it was in Kingfield, but I couldn't say it. So we went to the hospital, they put me through all the tests, they didn't find anything. They did find I had a brain. That's about all they found. But so
you have a brain and a heart.
I have a brain and a heart, so
That's
I'm good to
start.
go. And I know that Dr. Gunther, every 3 years, checks me out for the rest of me. And I come out with a clean bill of health and I even get a certificate at the end of it. So let's walk through a stroke.
Again, variable presentation with a stroke. And it could be anything from word finding, having trouble word finding, having trouble speaking. Some patients have, you know, a facial droop where your face can droop. It may not be a facial droop. Maybe it's arm weakness. Maybe it's leg weakness. So these are signs and symptoms of a stroke. The important thing about a stroke is that you don't wait, because there's a window. We have a window to where we can do something about it, where I can give you a medication. Because again, just like a blockage of the heart, a stroke is a blockage of one of the vessels in your brain. And you have to open up that blood vessel to make sure that blood is getting to the area of the brain that's deficient. And we have a window to which we can do it. Now, if you start having signs and symptoms of a stroke yesterday, there's nothing I can do today. You know, if you come in within 90 minutes, okay, we're within a window. And that may be maybe me not doing anything, it may be me getting you to, again, Lewiston or Portland as quickly as possible so that they can do something, so that they can open up the blockage. But they're different types of strokes. One is a hemorrhagic stroke where you're bleeding into your head, different from a blockage where the brain isn't getting enough blood and that area of the brain starts to die.
So what's the difference between that and an aneurysm?
An aneurysm is an abnormal dilation. So if you take like a balloon, it's bigger. The blood vessel is bigger. And as the blood vessel gets bigger, the wall of the blood vessel gets thinner. So you worry about an aneurysm, as you can imagine, if it gets big enough, it's going to pop and it starts to bleed into your head. So that's an aneurysm.
And I had heard about strokes and how critical it is to get there right away, because there is an injection or something that you can give a person that can make a huge difference on their
Absolutely.
recovery.
And not with an aneurysm. Now, an aneurysm, if you're bleeding and I give you a medication to open, you're going to bleed more.
Yeah.
Right.
Yeah. So wow, that's fun. It's again, those are the two big ones that are out there. I would assume that they're two of your bigger emergency room kind of handling, or is it stitches and drunks?
Honestly, we see a lot of abdominal pain.
Oh, really?
We see a lot of abdominal pain. We see a lot of trauma. We see a lot of trauma, not just in the wintertime with Sugarloaf and Saddleback and all the snowmobile injuries, but in the summer as well. We see a fair bit of trauma.
So trauma is broken bones and cuts and bruises?
Absolutely. Car accidents, broken necks, broken chests, flail chests, bleeding into your stomach.
Wow.
We've seen some really, really bad accidents.
And in most cases, those are the ones you still have to stabilize and move out, or
Absolutely. Those are the ones that we have to stabilize and move out as quickly as possible.
So how has COVID affected all of this, besides drive you nuts?
One of the things that I think people don't realize is, and I noticed this even 10 years ago, is that the volume has been increasing. The number of sick people that we're seeing is increasing. And just prior to COVID, we got to a point where there are no hospital beds open in the state of Maine. Right? If I need to get you admitted, I can't, because there's nowhere I can admit you. Maine Med is full. Lewiston's full, Bangor's full, Maine General's full, Southern Maine's full. Every hospital bed is full.
This is pre-COVID, or
this is pre-COVID. This is pre-COVID, and it started becoming. You would have a day every once in a while, and then it became more frequent, and it started to become more frequent prior to COVID. So what COVID has done is now you have another thing that needs to be dealt with on top of everything else that you're already dealing with. So it's not just COVID, it's everything else and then COVID. And so now a system that's already stressed is going to break.
Wow. So, in the case of COVID, I can see what that came out of somewhat nowhere. I've always anticipated there's going to be something that comes in.
Right.
This population is getting older. We're more susceptible to something, although COVID didn't really discriminate too much. The old guys, we were in deep trouble. Fortunately, I'm in good health, and as soon as I get my shot, I got my shot, because I didn't want to fool around with this at all. But has COVID now, have we seen the influx? I know Franklin County has now been identified as one of the moderate to high influxes of the variant. Is that having an effect on Franklin?
Absolutely.
Yeah.
Absolutely. I think COVID is having an effect not just on Franklin, but the entire state of Maine, if not the country. And the healthcare system in the country was stressed, prior to COVID. The hospitals in New York City, now that you put COVID on top of it.
Yeah.
If we were short-staffed before COVID, we're definitely short-staffed with COVID.
So what are some of the symptoms one would pay attention to for COVID? I think I know them, but I'll ask you as the doc.
Oh, of course. The big thing are fevers and chills, just like with influenza. A cough, some shortness of breath, fevers, chills, not feeling well.
That's pretty much what it comes down to. So you just kind of feel lethargic
and feel lethargic. There's some COVID, not a variant of COVID, but variable presentations of COVID, where I have some patients who've come in with nausea and vomiting or abdominal pain, things like that. But that's those are smaller number of cases. The majority will come in with fevers and chills, just like with most viruses.
Wow. So here's the question I'll ask you now. Now we got 5 more minutes. Some of your most interesting cases that you've had come in front of you. You don't have to diverge any names or anything like that.
No.
Like somebody ate a rabbit or something like that.
Oh, I've seen it all. I think after you've been doing this for a while, one of the things I was telling my new docs is I'm really surprised. I'm really surprised. And I can mention cases. The thing is, someone would say, well, that's me.
Oh, yeah.
But it's actually not. I've seen so many. I don't know if I have one interesting case. I have a lot of memorable cases. I have kids who I've lost who I don't ever forget about. Those are the. It's memorable in a different way.
Yeah.
You don't live stuff like that down. But all kinds of interesting things. People put things in wherever, so we see all of that.
When I was a kid, I was at the dentist's office, and the burr in the drill,
yes,
it flipped out, and it hit me in the back of the throat, and I swallowed it. So they're all like, oh my God, did it go to his lungs? Where did it go? So they moved me to the hospital, and you took an x-ray, and there was, sitting literally in my stomach, was a dental burr. Let's just say that I had a unique experience while it worked its way out of my system. I was 10 years old, sitting on a kiddie's potty, so that we could make sure when it came out. That must have been. I must have had somebody talking about that.
Oh, we see those. You worry about that if it's a battery, because.
Oh yeah, because it could leak or have something like that.
Absolutely.
Yeah, and I bet you see. How about Tide Pod, the pods, the fish? Have you seen any of that come in?
I haven't.
No,
I haven't. I'm sure some of my partners have, but I haven't seen the Tide Pods. But people swallow things, kids swallow things, adults swallow things. Make sure you chew your food as you get older. I see a lot of older people coming in with food that's stuck in their throat.
Really?
That doesn't go down. Oh yeah.
Wow. Huh. Interesting.
Yep. Chew your food.
Oh, cool. So anything that you want to add at the emergency room so the public has a chance to react to that or see that?
I would say be mindful of why you're there. It's not, we don't make you wait because we want to make you wait.
I thought that was why. I thought it was all trying to get even with them.
Well, it was different with you.
Yeah,
it was different. We knew you were coming. We had to, no, it's just, things are going to get busier. If you really need to be in the emergency room, we're always there. But if you don't and you can wait to see your doc, I have a lot of patients who come in and say, well, I just couldn't wait to see him, and I've come in. It's stress, and it takes time away from someone that does need to be seen. So just be mindful, and if you do come in and you have to be seen, we will see you.
Yeah, I mean, it's interesting. I stepped on a nail, and I knew I had a problem. So I was getting ready to go to the emergency room, and then I called Dr. Bien's office, which I hadn't thought about, and he called me back, and I told him what I did. And says I'm smart enough to know what I did, and stupid enough that I actually did it. Wrote me a prescription on the phone. I mean, we could see the red on the bottom of my foot, and it was very hot, and I didn't have to go to the emergency room.
Right.
The interesting story was, and I remember, I'm a almost 71-year-old man. Never in my life have stepped on a nail. Never. 2 weeks later, I stepped on another nail. And I call him up and I said, Steve, you're not going to, again, it was after hours, so I could have gone to the emergency room, but a simple phone call him to describe to him my symptoms. He said, you've done it again. And the prescription was written, and I went back and did my antibiotic. And fortunately, I had my tetanus shot, so I was in good shape there. So, but again, sometimes it just takes a simple phone call if you've got a primary care physician. And for some insurance companies, they actually have a nurse on call 24 hours a day. So if you call them up and describe their symptoms, they also can tell you kind of what you should do and what you should do. In fact, I think the reason when I called that person, she said, well, have you called your primary care physician? I said, I hadn't thought of that because I didn't think of it as a way to go. So that keeps people out of the emergency room.
And we have some wonderful primary physicians in this area. We need more of them, but the ones who are here are wonderful, and they do everything they can to get their patients in.
Yeah, no, I mean, Franklin Memorial is a special place. I mean,
it is.
It's one of the reasons why when we moved over here from the Bangor area, we located in Wilton because it was just a couple miles away.
Right.
And as a kid, I spent a lot of time in the emergency room. I broke my arms, my wrists, my face. I did a little bit of everything. Like I said, I had ADD. I tried to get around.
But you've got the 71.
I got to 71, you know, and I got the genes that go longer. And now that I know I have a heart, a head,
And a brain.
and the rest of me, I'm all in good shape. Abby, I want to thank you for coming on.
Thank you
That
so
was
much for
great.
having me.
It was,
It was a
pretty
pleasure.
great. And it's good to have you in the area.
Thank you.
I won't say I look forward to seeing you someday in the hospital, but I hope I see you around.
Absolutely.
All right.
Absolutely.
Hey, thanks for tuning in to Talkin, Maine. If you've got an issue, the emergency room is there for you in Franklin County. Call your primary care physician first before you head in, or your insurance company. Thanks for tuning in. We'll see you next time.